Hi class. In this lecture, we will review antipsychotic agents. The objectives are listed on the slide. They're also listed in Blackboard under the antipsychotics module. Please review the relevant vocabulary. Several of these terms are related to adverse effects that are seen with these medications, so definitely know what these terms mean. All right, so let's get started. The antipsychotic drugs are a chemically diverse group of compounds. They're used for a broad spectrum of psychotic disorders. Specific indications include those listed on the slide. Some of these will not be shocking to you. Obviously, schizophrenia. This is where these drugs get their name. But other similar disorders, delusional disorders, bipolar disorder, and you can see the rest of the indications listed on the slide. One thing I do want to point out is that these drugs should not be used for psychosis related to dementia in older adults. There's actually been increased mortality associated with the use of these drugs in that setting. So these drugs have been around for quite some time. They were introduced in the 1950s, and treatment for these patients has dramatically improved as a result of these drugs becoming available. Previously, these patients were institutionalized, and now almost all of these patients are able to live in the community, especially with effective drug therapy. So these drugs are used to control the acute signs and symptoms of bipolar disorder, to treat Tourette syndrome, which is a disorder characterized by motor tics. They are actually also used for suppression of nausea and vomiting because of the dopamine blockade. And then again, some of the other disorders. The primary discussion that we'll have around these drugs will be for the treatment of schizophrenia, however. So let's talk about schizophrenia. It's a chronic illness. It's characterized by disordered thinking and reduced ability to comprehend reality. Symptoms typically emerge during adolescence and early adulthood. More than 3.2 million people are affected by this disease in the United States. It's about 1% of the worldwide population. It is known that there's some sort of genetic basis, although it's not exactly clear what that link is. So the exact gene mechanism is unknown, but it is known that first-degree relatives of a patient with schizophrenia have a 10% risk of developing the disease. So I'll quickly review some of the pathophys, although the problem is this disease really is not completely understood. There's strong evidence that there's a biological basis, but the exact etiology of that is not known. It's thought that there are genetic, perinatal, neurodevelopmental, and neuroanatomic factors that all could be involved. But again, exactly how all of these factors interact to produce a patient that has schizophrenia really isn't understood. In terms of the underlying pathophys, there are a variety of theorized mechanisms that we're not going to talk about in our class. You may have heard of some of these theories previously, possibly in your pathophys class. But just to give you a flavor of kind of what some of those theorized mechanisms are. One mechanism is that there's too much dopamine receptor activation, and that's probably somewhat close to the truth because, as you guys will learn soon, the drugs that we use block the activity of dopamine in the brain, and they have success at resolving symptoms. But that can't possibly explain the entire underlying mechanism. So there are other mechanisms that are theorized that have to do with a dysregulation of dopamine as opposed to too much dopamine. Other theorized mechanisms that have to do with insufficient glutamate receptor activation, and I can go on and on. So again, we're not really going to get into that nitty-gritty, but I do think it's wise to appreciate that there's definitely something to do with dopamine, and the drugs that we use that are effective block the activity of dopamine in the brain, as you guys will learn soon. In the end, we definitely know dopamine is kind of a key factor, a key neurotransmitter that undoubtedly plays a role in the pathophysiology of schizophrenia. So I mentioned positive symptoms. Positive symptoms are really just an exaggeration or distortion of normal function. And just so you know, we're going to talk about first generation and second generation antipsychotics, or typical and atypical antipsychotics, as they're also known. And both of those drug classes are equally efficacious at treating the positive symptoms. I think the positive symptoms are all kind of things you've probably heard before in relation to schizophrenia, kind of the typical profile that some people have of a schizophrenia patient. You might think of a patient with hallucinations, or someone who hears voices, someone who has delusions, kind of, external forces are kind of out to get them, so to speak. In many cases, these patients have disordered thinking or disordered speech. They tend to be combative, easily agitated, and also they tend to suffer from paranoia. And these are all what are known as positive symptoms. The negative symptoms are really loss or diminution of normal function. And again, both the first generation and second generation antipsychotics both treat the negative symptoms. So the symptoms that are considered negative are kind of like withdrawal type symptoms. So you withdraw socially, emotionally, you just aren't motivated, don't really speak, don't have much to say. The patient's affect is very blunted. And then these things, of course, can lead to poor insight, poor judgment, poor self-care. And then there are also cognitive symptoms, because this is a CNS disorder. So, cognitive symptoms around maintaining goals, focusing attention, prioritizing, learning, or problem solving. None of these are shocking, I would say, considering the positive and negative symptoms that patients experience. I think it's really just an extension. These cognitive symptoms are likely really an extension of those positive and negative symptoms. Other things that other types of symptoms these patients may have, they could be abusive, hostile, be prone to self-injury, and in some cases even have increased sexual activity. Okay, so let's talk about the pharmacology of the antipsychotics. So these drugs fall into two major groups. The first generation antipsychotics, these are also called typical antipsychotics. These drugs have been around since the 50s. The word typical is kind of the older term for these medications. A more current term is first generation antipsychotics. On my slides, I abbreviate that FGA. The other group are the second generation antipsychotics, and these are also known as the atypical antipsychotics. Again, I will refer to those as the second generation antipsychotics, and I will abbreviate that on the slides SGA. So these are pretty popular drugs. Three of these drugs are three of the top selling U.S. medications of all time: aripiprazole or Abilify, quetiapine or Seroquel, olanzapine or Zyprexa. I'm sure you've heard of those before. The commercials, there are commercials all the time on TV for these drugs, which probably accounts for part of at least why they're so popular. Just to give you an estimate of volume, these drugs made $19 billion with a B, billion with a B, in 2011. The second generation antipsychotics outsell the first generation antipsychotics by a factor of 10. I think a lot of this has to do with marketing. Additionally, there's a perception that these drugs cause less side effects, although you'll see when I start reviewing the drugs that that's not necessarily true. There is also a lot of off-label use with these second-generation antipsychotics, and I'll touch on that a bit. Usually a second-generation antipsychotic is used for patients that are newly diagnosed with schizophrenia. However, if a patient who has schizophrenia is already on a typical antipsychotic and they're doing well, they'll probably continue with that typical antipsychotic. This is a disease state where you might have to try different drugs to see which one is the best for the particular patient. So goals of therapy. Obviously, you want to suppress those acute episodes and prevent acute exacerbations because those can be life-threatening for your patients. You want to minimize serious side effects, and you want to improve the patient's social functioning. You want them to maintain the highest possible level of function while decreasing those positive and negative symptoms, both acute and chronic, and to every extent possible, minimizing side effects of the medications.
Okay, so let's talk about the prototype drugs. So there are two groups, as I already mentioned, the first generation antipsychotics, or FGAs. Remember, these are also called typical antipsychotics. These fall into three categories, so three subcategories: low potency, medium potency, or high potency. For our lecture, we're only going to talk about one drug, and that is haloperidol, and that's a high potency agent. If you guys want to learn more about this, you're welcome to do so. There is extensive discussion in your textbook about it. For NCLEX purposes, you just need to know one prototype first generation antipsychotic, and really the one you're going to see more than any of all of these combined is probably the high potency agent haloperidol. We'll also talk about the second generation antipsychotics, and we will use one specific prototype for the second generation antipsychotics.
All right, so I'm going to talk about the first generation antipsychotics first. I'm going to talk about kind of side effects in general, and then I'll talk about the two prototype drugs that I want to review and some details about the pharmacology of those drugs. But I'm going to start off with the adverse effects because the adverse effects for first generation antipsychotics are pretty similar across the class. So these drugs are listed on page 319. They are listed in terms of the potency, whether they're low, medium, or high. Frankly, I don't think that's something that you necessarily have to memorize. I will tell you this, that the high potency agents like haloperidol tend to produce certain side effects that the low potency agents don't produce. So if you want to memorize how they're classified, that's the way I would find it useful in terms of their propensity to cause side effects or adverse effects. They are equally effective. So across the board, chlorpromazine, haloperidol, and some of the others are considered to be equally effective at reducing symptoms, but they do have varying potency. And remember, potency is only an important concept when we're talking about comparing drugs that do similar things to each other. And so if I say something has a higher potency, that just means it takes a lower dose of that drug than another similar drug to produce the same effect. These drugs block dopamine receptors in the brain, in specifically the mesolimbic area of the brain, and that's where the therapeutic effects come from, but also some of the side effects. Just so you know, these drugs also can block acetylcholine receptors, and that will produce side effects. We would call those anticholinergic side effects. These drugs can also block histamine receptors, and again, this can cause side effects like drowsiness. And they can also block alpha-1 adrenergic receptors. And so this can also lead to some of the side effects that are seen with these medications. So in terms of the therapeutic use, these drugs are used to treat schizophrenia. They're most effective at decreasing the positive symptoms. And you can look back at slide 4 to see what I mean by the positive symptoms. They can also reduce the negative symptoms, but they're known to be the most effective at reducing the positive symptoms, such as hallucinations and delusions. So adverse effects, I think one of the most important things about the antipsychotic agents, especially for nurses, is to have a good understanding of the adverse effects. The most important adverse effects associated with the first generation antipsychotics, and in fact second generation antipsychotics as well, are the extrapyramidal symptoms. These symptoms can be debilitating all the way to up to life-threatening. So all of the first generation drugs produce strong blockade of dopamine in the central nervous system. Thus, they can produce serious movement disorders, and these are known as these extrapyramidal symptoms. The second generation agents produce a moderate blockade of dopamine, but they also have a strong serotonin blockade, which we'll talk about when we get to the second generation agents. So the risk for EPS symptoms is lower with the second generational agents. However, it's not completely eliminated. These second generation drugs can still cause these extrapyramidal symptoms that I'm about to talk about. Just know that the risk of that is dramatically lower. So let me just kind of go through the extrapyramidal symptoms and what they are. So they're movement disorders. They result from the effects of the antipsychotic drugs on the extrapyramidal motor system. You guys might remember this. This is kind of similar to the symptom that's responsible for the symptoms of Parkinson's, which isn't surprising because Parkinson's is a motor disorder, and these symptoms are largely motor symptoms. So as I said, that strong blockade of dopamine is what's suspected as being the underlying cause of these symptoms. And then, so what happens is you've got that blocking of dopamine in the nigrostriatal pathway, and then that leads to an excess of acetylcholine, and that acetylcholine is what's excessive acetylcholine that's going unchecked is what's responsible ultimately, what they believe is ultimately responsible for some of these motor symptoms. So the first three listed here, acute dystonia, Parkinsonism, and akathisia, uh, these all tend to occur early in treatment, so within days or within the first month of treatment. These are much more common with the high potency first generation agents such as haloperidol. Now, other drugs can cause these, but these three symptoms are most likely to be caused with the high potency agents as opposed to the other first generation agents or even the second generation agents. Tardive dyskinesia is the other extrapyramidal symptom. This symptom can occur at any point in therapy, so it's not just associated with the initiation of treatment. It can occur at any point. And also, both the first and second generation agents can cause this. And it can occur with equal frequency with any of the first generation agents. So the low, medium, or high potency agents, they can all cause tardive dyskinesia, as well as the second generation agents. The other adverse effect that I want to mention is neuroleptic malignant syndrome. This is rare, but it's extremely serious. It has about a 4% mortality risk. And in fact, even 10 or 15 years ago, that risk was even higher, even as high as 20 or 30%. But nowadays, because we are so much more familiar with the symptoms and we know that prompt treatment will decrease mortality, the mortality risk has dropped dramatically. This is more common with the high potency first generation agents than the low potency agents. And just remember, this has to be treated immediately in order to reduce the risk of mortality for patients.
Okay, at this point, what I'd like you guys to do is pause this tape, and I want you to watch both of these videos. So you can just click on the link, it'll bring you to YouTube, and each section is about 10 minutes. You have to watch them. This is probably the best part of this lecture. And that means a lot for me to say that, considering it's the part that I'm not providing. But really, what you're going to see in these videos are people who have the different extrapyramidal symptoms, and I think it really brings it to life. So I think you guys will really like it. Please invest the 20 minutes to take a look at those. When you're done, come back to our video and I will briefly go through each of the 4 types of extrapyramidal symptoms.
So acute dystonia. So I'm going to go through each of those different side effects, and you guys got to know this. This is important stuff to know in terms of monitoring therapy for patients on antipsychotics. So acute dystonia is just a sudden dramatic contractions of the skeletal muscles. Involves the head, neck, back, laryngeal muscles. You can see involuntary upward deviations of the eye muscles. You can see spasms of the back muscles causing the trunk to arch while the limbs and head kind of thrust backwards. It is quite an impressive sight to see somebody that's suffering from this. It can cause joint dislocation, laryngeal dystonia. It can impair respiration. This is treated as a medical emergency. So the patient has to seek treatment or they could die from this. So it's treated with anticholinergic drugs, such as, or drugs with anticholinergic properties. So it could be atropine, but it could also be drugs with anticholinergic properties like diphenhydramine or benztropine, which is an anticholinergic drug. Generally develops early in therapy, or around the time of a dose increase. So even if the patient's been on therapy for a while, if their dose is increased, this could happen early on as that dose increase starts to take effect. Parkinsonism this is kind of like pseudo Parkinson's. So this looks like what you would see of a patient with Parkinson's disease. They're stiff, they've got a shuffling gait. They've just kind of got that Parkinson's like picture. And basically, this is because these drugs block dopamine in the striatum, and then that causes that imbalance of dopamine and acetylcholine activity. And so, uh, again, this develops early on, usually within the first month of therapy. And the treatment is to either decrease your antipsychotic dose. So the idea here is you're reducing some of that dopamine blockade if that's possible. Sometimes that's not possible because the patient's symptoms are too profound. Their antipsychotic symptoms are still profound, or they're being effectively managed at that dose. So instead, you might add an oral anticholinergic drug, and that would be to counter the effect of the dopamine blockade. Because if you block some of your acetylcholine activity, then you're bringing that dopamine and acetylcholine kind of back into balance, so to speak. Akathisia. This occurs most commonly with high potency first generation agents like haloperidol, just like the last two that I talked about, tardive dyskinesia and Parkinsonism. The thing about akathisia is it's uncomfortable to watch somebody with this. They can't sit still, they move around. In many cases, this is mistaken for either anxiety or agitation. It also tends to develop early in therapy. The treatment for this doesn't respond as well, unfortunately, to anticholinergics. It could respond to a lower antipsychotic dose, or maybe using a different antipsychotic agent. So if the patient's on a high potency first generation drug like haloperidol, maybe switching to chlorpromazine or maybe switching to a second generation agent will help with the symptoms. Another way to manage some of these symptoms is by using either a beta blocker or even a benzodiazepine, because the patient is experiencing kind of overwhelming agitation and anxiety. And those drugs can help to minimize some of the impact of that anxiety. Propranolol is a great drug for this. It's drug of choice because it's lipid soluble, it crosses the blood-brain barrier very well, and it can help alleviate some of the symptoms. Okay, so the fourth extrapyramidal symptom is tardive dyskinesia. I already mentioned that the incidence of tardive dyskinesia for the first generation agents, either low or high, and the second generation agents um, is really the same kind of across the board. So there isn't one group of agents that stands out as causing more tardive dyskinesia than others. Unlike the first three, where we said that the high potency first generation antipsychotics are the most likely to cause akathisia, Parkinsonism, and acute dystonia. Tardive dyskinesia, on the other hand, any of the antipsychotics can cause this. This is characterized by rhythmic, involuntary movements of the tongue, lips, or jaw. So you'll see the patient will have like lip smacking, they'll have these kind of slow worm-like tongue movements. This can lead to eating problems, can lead to malnutrition. Unfortunately, there's no reliable management. Prevention is key for preventing tardive dyskinesia. So if the patient's on a first generation agent using the lowest possible dose for the shortest possible time, now, I say that with a grain of salt. A lot of these patients are going to be on these drugs for a prolonged period of time. But if you can get them to the lowest possible dose, that's going to be desired. That's going to help minimize some of these problems, such as tardive dyskinesia. If the patient is on that drug for more than a year, which is typically the case, then the patient needs to be monitored every 3 months for development of tardive dyskinesia. You want to try to catch it early and minimize the impact, because it's just not easy to manage. In terms of the second generation agents, of those, clozapine and quetiapine, or Seroquel, have a decreased risk of tardive dyskinesia. And why I mention this is if you do have a patient who's on a first generation agent or even any of the other second generation agents, and they develop tardive dyskinesia and you catch it early enough, you can discontinue that drug and start the patient on either clozapine or quetiapine to help minimize the risk of tardive dyskinesia recurring. All right, and so the last very serious adverse effect I'm going to talk about in relation to the first generation agents is neuroleptic malignant syndrome. This is not an extrapyramidal symptom, but it is as serious, if not more serious. So it's rare but serious, as I said, 4% risk of death, down from around 30% previously. And this is largely due to early diagnosis and intervention. So it's very important to recognize the signs and symptoms immediately, report them so that the patient can receive effective treatment. It can occur with any antipsychotic agent, first or second generation. However, it's most concerning and most common with the high potency first generation agents, such as haloperidol. So signs and symptoms tend to evolve over a day or a couple days. And what you see is high body temperature. You see autonomic dysfunction. So patients can't control their heart rate and their blood pressure, their sweating, their respiratory rate is all over the place. They've got what's known as lead pipe rigidity. So, their extremities are like literally like lead pipes. They can't really move around too easily. They've got issues with level of consciousness. They could have seizures, they could have coma, they could have death. Generally, death is a result of respiratory failure and cardiovascular collapse, but also could be a result of dysrhythmias. Um, and so, in terms of treatment, this is important. You guys need to be familiar with neuroleptic malignant syndrome. You need to be familiar with the treatment of neuroleptic malignant syndrome and the signs and symptoms so that you're able to recognize this if you encounter a patient that potentially has this and help them get effective treatment as soon as possible. First of all, the antipsychotic has to be discontinued. Now, the question of whether they'll get another different antipsychotic sometime in the future, yes, they probably will. But you wouldn't, once they recover from this, it's usually a couple weeks before you'd restart their antipsychotic medication, or not necessarily you, but before the medical team would restart their antipsychotic agent. And in that case, generally, if they were on a first generation agent, they're definitely going to be switched to a second generation agent. But it really depends on what drug precipitated the neuroleptic malignant syndrome. But first and foremost, whatever drug that is, it's going to have to be DC'd immediately. Secondly, supportive treatment. So I said that these patients have all kinds of different autonomic dysfunction, body temp dysfunction, and so forth. And so making sure they've got appropriate supportive treatments such as cooling blankets, antipyretics, and then also other drugs that can be used to decrease some of the symptoms. Dantrolene, bromocriptine, benzodiazepines, these are all other drugs. Definitely be familiar with dantrolene. That is really one of the main drugs that is used to treat some of the symptoms of neuroleptic malignant syndrome. So some other adverse effects. So I mentioned anticholinergic effects, and this is related to the fact that these drugs tend to have tend to be antagonists at acetylcholine receptors. So they block acetylcholine basically. These anticholinergic effects are a little more common with the low potency agents such as chlorpromazine, but they cause things that you guys already know: dry mouth, blurry vision, urinary retention, constipation, things like that I know you guys are already familiar with your anticholinergic side effects. Orthostatic hypotension. You may remember I mentioned that these drugs can also block alpha 1 adrenergic receptors, and that can lead to orthostatic hypotension. They can cause sedation. They are centrally acting drugs, so they can cause sedation. Luckily, with most of the time, the sedation subsides over time because the patient develops a tolerance to it. But it is something that you would want to make sure your patients are aware of. Could cause seizures, neuroendocrine effects, sexual dysfunction. I think another big one, I should have bolded this on the slide, is agranulocytosis. This is much, much more common with the second generation agents, and in fact, it's a huge concern with the use of clozapine, which is a second generation agent. But it is possible for first generation agents to cause agranulocytosis. These drugs can cause severe dysrhythmias. And I'm just looking at the slide, I realized that dysrhythmias is not spelled correctly. I apologize for that. But so severe dysrhythmias, dementia, especially in older patients, or even extrapyramidal symptoms or withdrawal in neonates. So we already talked about the extrapyramidal symptoms at length. But if a baby is exposed to these in utero, when the baby is born, that baby can experience symptoms of withdrawal or even have some extrapyramidal symptoms.
Okay, so let's discuss the nursing implications for the first generation antipsychotics. So, obviously, in all cases with medications you're about to prescribe, you want to identify high risk patients who shouldn't get whatever that particular drug is. In this case, we're talking about first generation antipsychotics, and there are a handful of patients for whom you would not want to administer the first generation antipsychotics. Now, if you've got, for example, a patient who is on other QT prolonging drugs and you're about to give them haloperidol, that's something that you might want to stop and discuss with the provider, for example. If you look in the back of the textbook or the end of this chapter in your textbook and go through the nursing implications, you can see some other examples of high-risk patients that you would want to identify. Promoting adherence. Adherence is key for these patients. Once they get better, they still need to continue these medications ongoing. Most likely they will not be able to discontinue these medications. So adherence can be difficult because there are a lot of adverse effects associated with these medications. Like the prescribers or the doctors in the video, they were explaining that if you can help these patients overcome some of those extrapyramidal symptoms, they can still maintain treatment. But in some cases, the extrapyramidal symptoms themselves lead patients to commit suicide, which is devastating because, for the most part, those symptoms can be managed if they're identified. So, promoting adherence, helping patients to identify early and late EPS symptoms, having them report them to their provider as soon as possible so that those can be managed appropriately. Additionally, we talked about the risk for agranulocytosis. So this is not as common with the first generation agents as it is with at least one of the second generation agents, but if it occurs, it can be deadly. So instructing patients to look out for fever or sore throat, those types of symptoms that would be indicative of potential agranulocytosis, and have those be reported to providers as soon as possible so the patient can be evaluated. And then, of course, lots of other adverse effects can occur with the first generation agents, such as orthostatic hypotension. So, educating your patients on ways that they can minimize the impact of those adverse effects. For example, if someone's experiencing orthostatic hypotension, you can tell them to stand slowly from a sitting position, for example, or be cautious about the risk for serious falls, things like that. And then finally, observing for neuroleptic malignant syndrome. And if you note that, taking action quickly. Remember, mortality from neuroleptic malignant syndrome in the past was as high as 30 or even 40%, but with prompt identification, the mortality associated with this syndrome can be dramatically reduced. All right, so let's move on to the second generation antipsychotics. Remember, I said these are also known as the atypical antipsychotics. So the prototype second generation antipsychotic is risperidone or Risperdal. The second generation antipsychotics have less affinity for dopamine receptors and more affinity for serotonin receptors. So they block dopamine and they block serotonin. However, in comparison to the first generation agents, there's less dopamine blockade. And so because of this, the second generation agents cause fewer extrapyramidal symptoms than the first generation agents. Now these drugs, just like the first generation agents, they also have the capability of blocking alpha receptors. They have the capability of blocking cholinergic receptors and histamine receptors. So of course, the same discussion applies as the first generation agents. These drugs, because they block histamine receptors, for example, can cause some sedation. Cholinergic receptors they can block, that could lead to anticholinergic effects, and so on. These drugs, obviously, they're used primarily for schizophrenia, and these drugs are effective at reducing the positive symptoms, just like the first generation agents. But they're also very effective for improving negative symptoms as well as cognitive symptoms. These drugs have been used in bipolar disorder, as we've discussed previously, and they can also be used in psychosis that's related to levodopa use. Uh, the risperidone in particular is available as tablets. It's also available in an orally disintegrating tablet, and there is an IM form, an IM depot form available as well.
Another huge risk with the second generation agents are metabolic effects. And so when these drugs came out, they were kind of touted as, the next great thing. They didn't cause as much extrapyramidal symptoms, but as patients started to use them, we started to see that more and more patients were experiencing negative metabolic effects. Patients were gaining weight, patients were developing new onset diabetes, and they were developing high cholesterol or dyslipidemia. And so, because of that, there are, again, monitoring parameters that are very important. They're not necessarily regulated by the FDA the way that the monitoring parameters are for agranulocytosis, but it's prudent for anybody prescribing these medications and for anybody administering these medications to make sure that patients are being adequately monitored. So, looking at BMI, measuring that on an ongoing basis, looking at fasting fasting blood sugar at baseline, and then evaluating that ongoing, and then lipids as well. Other adverse effects with the second generation agents, these are all pretty rare. They can happen. So if for your purposes, I think knowing about agranulocytosis for second generation agents, knowing about the metabolic effects is of the utmost importance. Also knowing that EPS can occur with the second generation drugs, although it's much less likely than with the first generation drugs. These drugs can cause tardive dyskinesia. Remember, that is the one extrapyramidal symptom that can kind of happen across the board with any antipsychotic. But they can also cause seizures, myocarditis, orthostatic hypotension, dementia in older adults. These are some of the things that could be seen, although they are rather rare, especially in relation to the first generation agents.
So, in terms of nursing implications for the second generation drugs, just like the first generation drugs, you want to identify the high risk patient population. I think probably one of the highest risk populations for second generation agents are those patients with diabetes or um, uh, pre-diabetes. And that's because we talked about the fact that these drugs cause metabolic effects. And so those effects can be worsened if the patient already has diabetes. We talked about promoting adherence. Of course, adherence is very important for patients who have schizophrenia. Remember, we have our acute treatment phase, and then we're going to have our long-term maintenance phase, and helping patients to minimize side effects so that they stay on their therapy, their regimen is important. And we're going to talk about promoting adherence in a few minutes, just in general, with both the first and second generation drugs. Educating patients regarding some important adverse effects like agranulocytosis. So we talked about this with the first generation agents. Agranulocytosis is more common with the second generation agents, and specifically clozapine, which I did mention previously. So it may be not as likely with risperidone, although it can happen. So letting patients know about fever, sore throat, any other signs that they might be experiencing agranulocytosis, and then of course instructing them to contact their provider immediately. The most important thing you want to educate these patients on is the risk of metabolic effects, weight gain, diabetes, what they should look for, ways to minimize weight gain, for example, what they should look for with regards to new onset diabetes like hyperglycemia and associated symptoms with hyperglycemia like polydipsia, polyuria, for example. So that's very, very, very important when you're educating these patients. Early and late extrapyramidal symptoms. Now remember, these are much less likely to occur with second generation drugs than they are to occur with first generation agents. But it is still possible. So patients do need to be educated on the possibility and what to do if they experience those, especially for tardive dyskinesia, because tardive dyskinesia occurs equally with the first and second generation drugs. So they definitely need to be educated about that. And then, of course, there are lots of other adverse effects associated with the second generation antipsychotics, such as orthostatic hypotension. So make sure you're educating patients on methods to minimize those problems. Finally, this is specific to risperidol, but when intramuscular therapy, that intramuscular depot therapy is initiated, with that first dose or that first injection, the patient's going to have to be continued on oral therapy for at least 3 weeks. And that's because with that first injection, it takes several weeks for the drug to reach therapeutic levels. So the patients will need kind of a bridging, so to speak, for the first several weeks of therapy with that oral dosage form.
All right, so let's talk about some ways to promote adherence in these patients. These drugs can be difficult. The disease state itself is a very difficult disease. It can be managed with medications. The problem is the medications bring a lot of side effects. And so adherence and making sure that the patient's actually taking the medication uh, and is able to take the lowest dose possible in order to prevent these serious side effects is important. Adherence is going to be a major factor in all of this. So let me just kind of go through some of the points. The first point, medication is swallowed and not cheeked. I think this is more of an issue for patients that are in more of an acute phase of psychosis or schizophrenia. So this is more likely something that you might see when your patient is admitted to a psych unit or a psychiatric hospital. I'm not sure how many of you will be working in that setting. I think for those of you who are going to work kind of in a general care setting where you might have a patient with schizophrenia but who's actively managed and their disease is under control, for those patients I think this might be less of an issue, but it is something to consider. Encouraging the family to oversee medication administration. A family, loved one, anybody who can help, a friend, somebody that can help. In many cases, that is going to positively promote adherence because these patients are notorious for not taking their medication, sometimes because they think that it's not helping them, sometimes because they're worried about side effects, but having that extra family support or kind of caregiver loved one support can be helpful. Providing written and verbal instructions, especially around side effects and how to minimize them. Developing a good therapeutic relationship with the family. Again, the family, friends, whoever the support system is for your patient. Bringing those people into the fold is only going to help the patient, especially in terms of medication adherence. Providing high quality education. So these medications have to be taken routinely. You can't just take them when you don't feel well. Explaining the adverse effects and how to minimize those. This is probably one of the most important things you can do for your patients to help them maintain adherence. Because if they're not managing the side effects well, then they're ultimately going to stop taking the medication, and that is probably not going to be a good thing for them ultimately. Finally, assuring the medications aren't addictive. Some patients have the misconception that these medications are addictive, kind of like, in the way opioids might be addictive. That is not the case with these medications. The last point is to use IM or intramuscular depot preparations. These are long-acting preparations that can be given anywhere from every 3 weeks up to 6 weeks, depending on the drug. It depends on how frequently it needs to be given. But it's clear how these can improve adherence because these medications are given by healthcare professionals, so they're actually being administered. And then secondly, they're going to last for several weeks, even up to a month or so. And because of the way they work, they are injected into the muscle, they're formulated in a lipid base, and then they slowly release drug over time. That allows for consistent blood levels, which is good because side effects can be minimized, and also ensures that the patient is getting their dose, so to speak, every day until they need their next injection. And so these depot preps, they're long-acting, injectable formulation. They're only given intramuscularly. They're usually formulated in a kind of a lipid carrier, which helps them to slowly dissociate from the muscle. They're a good option for long-term maintenance therapy. They have been shown to have a lower rate of relapse compared to oral therapy. I think that's kind of common sense. I mean, it's not surprising to me that that would be found because you're ensuring that the patient's actually getting the drug. They have a reduced risk of tardive dyskinesia, and there's some thought that that's related to the consistent blood level versus peaks and troughs that you might see with oral administration. Um, Dosing interval anywhere from 2 up as far as 4 weeks. But there is a big safety issue with these drugs. You've got to be aware of the fact that these cannot be given intravenously. There are intravenous forms of some antipsychotics, such as haloperidol, but haloperidol is also available as an intramuscular form. If that intramuscular form is injected intravenously, it can harm the patient for a multitude of reasons. So you definitely need to be familiar with that safety issue. So in terms of drug selection, um, effectiveness is, one of the biggest questions. Um, these drugs are considered, both the first and second generation drugs are considered equally effective. Now, with that said, dosing is highly individualized. You always want to use the lowest effective dose. With any drug, that's true, but with these especially because the side effects can be profound. Um, so, it's kind of a function of what's the most effective drug, what's the most tolerable drug, and then cost can be a factor. The second generation agents can be very expensive. So, in terms of first versus second, as I mentioned, they're equally effective. The only exception to that is clozapine. Clozapine is an extremely effective antipsychotic drug, but it has a very, very serious side effect associated with it that we will talk about. But it is extremely effective. So, because of that, we usually reserve it for cases that are refractory to other drugs. And when I say refractory, I mean they just don't respond to the other antipsychotics. So, for those patients, generally clozapine will work, but because it's got such a severe side effect that can be life threatening, we reserve that drug for special occasions. The second generation agents do have a lower risk of extrapyramidal symptoms, and this is a definite positive. However, they do have a higher risk for metabolic effects, and they can be just as debilitating. Finally, the first generation drugs are definitely less expensive than the second generation agents. So if cost is a significant factor, that is a factor that might lead towards that patient using a first generation drug. And that is it. Thank you guys for listening. I hope you found this to be a helpful lecture. I always found these drugs to be quite fascinating myself. I think a lot of that stems from the fact that they cause so many side effects, and these side effects are very recognizable, and they require intense monitoring and very good, high quality patient education to help minimize them. If you have questions about this lecture, please post them on the discussion board, and I will do my best to answer the questions. You can also check your textbook. There's a wealth of great information in the textbook as well. Thank you for listening.